Good morning, everybody. This is going to be a fun morning for all of you the on the Zoom link. Okay, so we have three wonderful speakers today, and they're all faculty. Diana Barrett Wiseman, followed by Franck Kalume, and then Patrick Fillingham, our young buck, is in the third slot. So they're going to speak for 15 minutes and answer 5 minutes of questions. And I'm going to just take a minute, indulge me so that I give you their backgrounds. I'm not going to spend hours on each one. Diana Barrett Wiseman was born in New York City and then emigrated. That's not the correct term, but went west, my son, and she went to California, where she eventually got her undergraduate degree at Berkeley, which started her rebel nature, I'm sure. She went on to join the military to pay for her schooling, and she got her Doctor of Medicine, AOA, at Uniformed Services University of the Health Sciences in Washington, in Bethesda, actually, but it's Washington, D.C. She is most famous with me because she did her neurological surgery and orthopedic surgery spine fellowship in 2003 when Chris Shaffrey was here. She went to UNC for her residency, surgical internship at Bethesda Navy. She has an MBA from Duke University Fuqua School of Business, and she also has a certificate in palliative care. She's a remarkable human being, and it's always hard to replace Rapport and Howe, Doctors Rapport and Howe, but Diana Wiseman has been just absolutely amazing, terrific, and there aren't enough adjectives of excellence that I can apply to her. She's not only a board certified neurological surgeon, she's a mother of 2 children, and her husband was a Navy SEAL and now is traveling as part of the McKinsey group somewhere in the world right now. So give her a nice round of high fives, and she's going to talk about some of the work she's been doing for our department. Pretty remarkable. Thank you so much, Diana. You're an amazing part of this team.
Well, Dr. Ellenbogen, thank you very much for the kind introduction and the opportunity to talk today. I wanted to share the first 3 months of findings for a pilot project with the Harborview Neurosurgery Length of Stay Committee. We've been studying the effect of a tailored medical social screening program in the preoperative phase for spine patients that are identified as likely to go over length of stay and the effect of this program on that metric. So many of you on this call understand that prolonged length of stay is not desirable for a host of reasons, some of which are listed here. Our medical literature is replete with studies identifying patient factors associated with prolonged length of stay. However, implementing projects to tackle these factors has been limited. The Enhanced Recovery After Surgery program is an example of a method that has been studied to tackle some of these factors. The program is largely focused on post-admission processes, however. Prolonged length of stay, however, has a myriad of factors, and you can almost think about it as like death by 1,000 cuts, and therefore there's not a simple fix. Based on our committee's findings, I designed a program to address these factors prior to admission for our elective spine cases. The program uses aspects of concepts from lean manufacturing, Six Sigma, and behavioral economics as it influences change management. So the program workflow is composed of these stages along the patient's surgical journey. And identification of patients at risk is the first aspect. So we did a deep dive on 6 months of data looking at patients that had gone over length of stay for Harborview neurosurgery elective cases, and we found that over 40% had gone over length of stay. The highest percentage were spine patients, followed by complex skull base and then vascular cases. Chart review of multiple cases revealed several common themes. And also within the neurosurgical literature, there are several studies that have been published that show common factors associated with extended length of stay, for example, for spine, as well as for ruptured aneurysms. So given this, we put together a pre-surgical screening for discharge planning And this is a dot phrase that is added at the end of a new spine consult. And where if any of these are, sorry about that. Well, if any of these pop positive or show up positive, then if the patient decides on surgery, this just alerts our PCC and APP team that the patient should be enrolled in this project and do an earlier pre-op screening. Just so you know, there are other screening systems out there, such as the Carolina Sims grading scale. However, we found that for our particular institution, and given the factors we encountered as that caused prolonged length of stay, this our dot phrase works well. And I think thanks to Michelle Mogaletta for putting it together in EPIC. So when a patient decides on surgery, they are then and have screened positive, they are enrolled into this program, and they are entered into a Excel spreadsheet where our team model is made up of our PCCs, APPs, the surgeon, that's me, social work, and our preoperative nursing, where we review each of these patients every single week. And what we're looking at is to optimize several of these medical and social factors before they get admitted. So what we have found is that we really have a focused, inclusive preoperative checklist that is aimed at length of stay. These are the factors that we have identified as being important to address for each patient before being admitted. And then we discuss any anticipated problems. Of note, you'll see that one of the important aspects is discharge expectations of where we think a patient will likely need after surgery and also what equipment they might need. Sorry, I'm having to slide things. Along that line, this is just an example of what one of our sheets will look like as we fill it out along the way. So our green status notes that this area has been addressed and we don't have any concerns about it, or it's been optimized as much as possible. And if there is still pending issues, we continue again to follow up each week until the patient has the surgery and trying to optimize everything that we can. Once the patient comes in for the inpatient phase, again, because I work both on the outpatient side and inpatient side, I'm able to follow their progress, especially during our social work and discharge rounds, and also alert the team that, again, this is a patient that's been involved in this study. And then once discharged, I've been reviewing in a spreadsheet, how each of these patients are doing over time. And so this is just an example of our spreadsheet, where what you will see here is that there are several cases that what is highlighted in yellow is that these are patients that did go over length of stay. This is by how much they went over length of stay. We have our section on anticipated barriers that shows us where we anticipated they would have problems. And then we have a section down below of why they went over length of stay. And there's going to be a certain theme that you're going to see here. So all the parts in green are patients that had significant opioid use or chronic opioid use before surgery. And here is, and then they went over length of stay primarily secondary to pain afterwards. And so, for example, this patient was still on ketamine drip during the day that they were supposed to be discharged. Next slide. Over time, we have been working to optimize our workflow for this program. And in the interest of time, I'll keep this very short and gloss over this part a little bit. But as Jan Ingvelson says, the social worker that's been working on this program, she says, we have literally been building the plane while attempting to fly it at the same time. And that one of our issues is that we're constantly trying to optimize our workflow and pivot what is not working. One of the things we found is that our preoperative nursing staff on 5NJB were making the initial calls. However, the number of people enrolled quickly became too much for them to handle within a short period of time. And therefore, when Jan started in the beginning of December, she said, let me make those initial calls, which has helped our workflow immensely, and also she records many factors that our pre-op nursing staff can use. And again, I'm just going to move forward on this. We noted issues sometimes, again, with missing patients that would make it through that should have been identified. And we worked on adoption of that, as well as adding a frailty scale into really trying to characterize how frail the patient is, as well as their health. And so we are just starting to implement that scale. Another thing we noticed is in terms of workflow is that our weekly meetings were becoming, we couldn't do them all in one meeting because it was just really a waste of time for some groups while they were waiting to hear about their particular patients. So we broke apart the meetings where really the APPs and PCCs that come, it is done during a time that works for that particular clinic. And we keep the review of their patients to usually within under a half hour. On the inpatient side, we noticed that there was we would do all this work, and then we would find that on the inpatient side, sometimes they just wouldn't see where we had put that work. And in Epic, once you start going a certain number of clicks into things, it's just too much. And so in honor of a bridge too far, Charlie Vaughn, as you'll see there, was giving me feedback about the program. And he said, why can't you just stick this information right in front of me? I want it in my progress note, so it's there so I don't have to click. So, and Charlie's right, we can do that. So what we did, we've been working on a new form of data entry. We have this currently, and this is examples of a build that's going on in Epic right now, where we're taking all of those Excel spreadsheet information, we're putting it into flow sheets within Epic, so we don't ultimately have to go to a spreadsheet. We're then taking parts of this information that is critical for the inpatient team to know, particularly about our interventions, and we're going to be able to pull those into a note. So just like when you open a progress note right now, and there's a vital sign section, an exam section, we can have a discharge planning section where you can see what has been done prior to the patient being admitted. This will work for social work, our CCN team, and our APP team, so that it applies to a principle of behavioral economics, which is if you want people to really adopt something, you can't make it sludgy. You have to really put it in front of them and make it easy. At the same time, this format allows us to do data collection, and so we're able to do reporting workbenches about the progress of this, and less digging right now through the chart, and more of that information right there in a reporting workbench. So this will hopefully go live within about the next about 3 to 4 weeks. Okay, wrapping up into the program outcomes for spine after 12 weeks. So 46 patients screened into the program with factors putting them at high risk to go over length of stay, and 31 had completed surgery and discharged. Now, 18 out of 31 went over geometric length of stay. That's 58%. So we knew these were high risk coming in, and you're going to say, wow, your program's really not doing anything. That was 58%. There are factors that we knew we could help with, and there are factors that we knew we could not help with, but we wanted to record them so that we could advocate for resources related to that. So some of the factors and what we found. Geometric length of stay is actually not calculated until the patient is admitted, and it can be a different number based on their insurance. Geometric length of stay is affected by the comorbidities that are listed with the patient during the time of pre-op. So there were 7 out of 31 patients where we said, hey, this geometric length of stay is really way too short for the size of the surgery as well as the comorbidities of the patient. And so after discussion with utilization management and the coding documentation team, it turns out that we have to list not only our spine diagnosis, but each of their comorbidities in the diagnosis field for to help use that for calculations. He said that just referencing the problem list, because problem lists are classically outdated, is not useful, and they don't do that. So this is a workflow that we will be adopting for the pre-op. So 9 out of 31 had medical or surgical complications, 5 were surgical. In regards to this area, one of the optimizations we've done is I think a more appropriate use of our medical operative consult service. And starting in November of 2022, we've really looked at the guidelines that were recommended for referral to that service. And plus with our inpatient APP feedback of patients that would benefit from this, we are a little bit more aggressive now on referring patients for a mock evaluation. And I will tell you, I got a call from Edie Shen, who heads the mock group. And she said, I don't know what neurosurgery is doing, but your utilization has been great. It's very helpful for them. And it also helps with the anesthesia clearance. So we've been working on that side. One area that was also approved was our PCPs. Patients would enroll in this and they thought their nephrologist was their PCP or an oncologist, but it turns out that that is not an appropriate PCP. And we couldn't get home health if they don't have a PCP. So for a while on neurosurgery, patients would sit on the inpatient side waiting to get better enough to go home with outpatient therapies. And so I discussed this with the aftercare clinic, and they will now serve as the PCP and then help patients find a new PCP so that we can get them out with their home health. Next slide, we're almost done here. Okay. Some of them, again, we had some discharge expectation mismatches. So patients, we told them where we thought they might need to go. They weren't necessarily happy with that, but what helps is that we can capture the discussions that we've had with them so that the inpatient team can start with that. In the interest of time, again, I will focus that our inpatient CCN and social work staffing has really been inadequate to cover the number of inpatients. And so there are several patients they can't get to during the day. And we're trying to better characterize that so it right sizes their staff. But the big finding was that 14 out of 31 of our patients were delayed secondary to pain. So there is no outpatient pain service at Harborview, and there's a backlog at UW Roosevelt. And so I called the pain service and discussed with Dr. Pepperzak at length about what we could do for these patients, given that even though APS is involved immediately post-op, we're definitely missing something. And so she literally, in the last 2 weeks, they are going to start rolling a program out at Harborview to do encounters. And so funding for this, provider availability, scheduled spaces for services and everything is still a work in progress. But over the next couple of months, we will hopefully see improvement of this so that we can talk to our chronic pain patients before they come in and set expectations. And then mental health was also a factor in delaying some of this, and this often went hand in hand with pain. All right, I will finalize this by saying that one of my favorite quotes is, if you're not at the table, you are on the menu. And so I know UW is wonderful for creating our neurosurgery program. We create a lot of surgeon scientists, but there's also a role for surgeon business leaders, in that since 1990, there's been a 3,500% increase in administrative staff compared to physicians. However, even with the significant increase in administrative staff, that doesn't necessarily help us in all the areas that we need help. So it is vital for surgeons to also be involved in some of the workflow processes, and as we really truly understand the needs of our patients, the needs of our service, and that building a program that incorporates end user feedback is very flexible to pivot, and is really an essential for change management. So again, in the interest of time, I'll stop there, and I welcome any questions.
That was great. Any questions for Diana?
Diana, this is Louis. Great talk. Incredible work that you're doing, but it's an uphill battle, and I appreciate all the effort you're putting in. Quick question is, how do you differentiate the impact of length of stay on your initiatives based on, sort of ERAS type measures that are already sort of being implemented, which is monitored by Scope and other organizations, entities, versus the social work issues that is really, kind of your brainchild and has made a huge difference already, as you pointed out. Thanks.
Yeah, so the ERAS procedures, we are doing some aspects of that in the preoperative phase, such as carbohydrate management. But the ERAS program, and Emily Jones, who's the spine line administrator, and I were talking about this, has not been implemented to its full extent here. I think particularly around some of the inpatient aspects. So I think that these are it's hard to differentiate what's doing what fully until we look at like what really, like on our drill down as to what really held the patient in the hospital. And so, for example, we see that many of the patients are related to pain. If the ERAS program is done a little bit followed more and can address the pain, maybe that will make a difference. But it gives us an idea of what we can focus on. And I think both programs are really complementary. This adds a bigger, robust aspect in the preoperative phase.
Thank you, Dinah. So we were at 20 minutes and I want to give Franck and Dr. Fillingham time to talk. This is a really important thing you're doing, Diana. We really all appreciate that. And it's, I know you're just it's a start. I mean, it should have been launched 20 years ago, but thank God we have you to do it. All right. So thank you, Diana. We go on to our next speaker, Franck Kalume, who has been in our department for now 15 years. Can you believe that, Franck? You've been in our department. Franck was born in Cambobi in the Democratic Republic of Congo. And if that sounds unusual, although he's an American citizen, if that sounds unusual to you, it should, because he's only the second PhD scientist out of that country, and probably the only scientist out of that country that's ever gotten an R01. So that is special. We poached him, or we recruited him from the Department of Pharmacology, where it was a fellow in Bill Catterall's laboratory, and we were told what a wonderful human being and scientist he was. And Nino Ramirez and Jeff Ogeman and I recruited Franck to the department, and he's been extremely successful with 2 R01s, and now on a U grant and applying for more grants. And his body of work has been very focused, and he's a wonderful partner for this department. We love having him here. Franck, without further ado, can you go ahead?
Yes, can you hear me?
Perfectly.
All right. Thank you, Dr. Ellenbogen, for this opportunity to present in the grand round. I just realized that it has been over 5 years almost since I last presented in this meeting. And as you can see through my title here is that the work that I will present today is an exciting work that focus on the development of gene replacement therapy for Dravet syndrome. And this is all in the preclinical setting. And we have the hope that we can take this work all the way to clinic. And I would like to start right away by with my acknowledgement slides here by noting that this work that I'm presenting is part of a big collaboration with my colleagues at the Allen Institute. Among them, you can see Adeline, who is a member of the department, and the others are Boaz Levy, Jonathan Ting, and John Mish. And the program also is include an investigator from Caltech, Viviana Granulado, and Greg Hortzwitz from the Primate Center at the University of Washington. And locally at Seattle Children, we have the Ramirez Lab, Aguan, and of course Nino from my great partner in this work. And in my lab itself, it's Judy, who is a technician, very talented technician, who started out as an undergraduate student in my lab, and she's the one who carried most of the work that I'll present. And of course, Michelle, Rose, and Mikhail and Arina also contributed to the work. And I'll say that for disclosure, we have an IP license. We have 3 patents and then an IP license with BioMarine. We decided to buy some of the technology that we developed for this work. This morning, I'll cover in the introduction a little bit about information about Dravet, and then move on to talking about the concept of the therapy that we are developing, and moving then after that we'll cover the characterization of the vectors property, and then the screening of the efficacy of the vectors in our mouse model of Dravet, and then finish up with a conclusion. So Dravet syndrome is very well known as a devastating developmental epileptic encephalopathy. And it has an incidence of 1 to 20,000 to 1 to 40,000 live birth, which represent about 7% of all severe epilepsies that start before the age of 3 years. Its clinical manifestation is very well defined. It was first characterized by Dr. Dravet in 1978. It's known that this disease is characterized by multiple seizures that evolve over time, and they are accompanied by several comorbid conditions, including motor abnormalities, cognitive impairments, sleep and circadian rhythm disturbance, autistic behavior. And we also know that Dravet kids are at high risk of premature death due to sudden unexpected death in epilepsy, status epilepticus, accident, or other causes. And most of the cases with Dravet are resistant to anti-epileptic drugs on the market, including even those that have been developed in the recent years. And so there is a very high unmet need to develop more efficacious treatment for this disease. Genetic studies have shown, beginning with the study by Kleis and his colleague in Belgium, that the primary cause of Dravet is an heterozygous loss of function mutation in STN1A. And this is the gene that's encoded for the alpha subunit of the NaV1.1 sodium channel, and leading to haploinsufficiency of the channel. And this cause of Dravet has been found in over 80% of the cases. So the background for this work is the extensive findings from our work for over 20 years, where we discovered that, and also even our colleagues in the field discovered the same thing, that Dravet is primary, that Dravet causing SCN1A mutation leads to reduced sodium current and excitability in interneurons without affecting excitatory neurons. And in addition, we know that key Dravet syndrome phenotype are recapitulated in mouse model when this mutation is specifically introduced in forebrain GABAergic neuron alone. And this suggests that Dravet syndrome is a disease of the forebrain inhibitory neurons. And so the hypothesis for this work is that interneuron can serve as a good target for gene therapy for Dravet. And to test this hypothesis, we had two very big challenges to overcome. One is that the SCN1A is a large gene, and it doesn't fit in the packaging cargo capacity of the AAV vector. Its coding sequence is about 6 kilobyte kilobases, and the AAV has a packaging capacity maximum of under 5 kb. And so that was the first challenge that we had to overcome. The second challenge is that how to target inhibitory neurons. And at the beginning of this project, there were only rare promoters or reporters that could do this. And most of the reporters and promoters are too large to fit even in the AAV. And so that's how we team up with the collaborators at the Allen Institute, who at the point were working on RNA-seq data and trying to mine these the large data set that they had to identify enhancer that they can use to build AAV vectors to target a desired population of cells. And of interest to us was the DLX56 enhancer, which they shown that they can label, using it, they can label inhibitory neurons in the brain with good confidence. So we decided to use this technology in our work. And the second thing that we did as a strategy was how to package a large gene like SCN1A in a virus. We use the technique known as a split intein splicing system. And in this case, what we did is that we use a system, and people in research have used this before. And this is a system that occurs naturally in some bacterial cells and even eukaryotic cells when they're building large protein. They will start by expressing only a peptide, two different peptides, for example, in this case for 2 parts, 2 different peptides independently. And this peptide will have an intein attached to one end of each part. And this intein little splicing element will find themselves and come together. And as they come together, they'll transplice the protein here, making a full-length protein and excising themselves. And they do all of this without even needing any enzymatic activity or any enzyme from the outside, only on their own. And so this is the method that I refer to as the IKEA-like approach, where part of the big protein come first delivered, and then they will come together at destination in our treatment therapy. And so this is the concept that we had for our therapy. We first tested this in vitro using heterologous cells. And so we built construct of DNA for the human SCN1A. And to do this, we built these 2 constructs by breaking the DNA at the point illustrated here in the cartoon drawing of a sodium channel. And so we had the N-terminus part and the C-terminus part of the gene in apart. And then each construct had a label so that we can identify them in our experiment. And they also had the CMV promoter for expression in heterologous system. And when we express this construct in CHO cells or HEC cells 293, we could see that only in conditions where we had the 2 parts expressed, we were able to record large sodium current. But in conditions where we had only 1 part of the sodium channel expressed, no sodium current was seen. And as you can see here in quantification, in the case where the 2 parts were expressed, we were obtaining a current almost the same size as when we have a full length expressed. And in the other control conditions, nothing was expressed. And this told us that these 2 parts of constructs that we built can express and reconstitute to make a functional sodium channel. And so this was the very first step, and it was very encouraging for us that we can do that in vitro. And so to send this into the animal, what we did is that we rebuilt the similar construct, but this time we used the DLX 2.0 enhancer. These are small guiding elements for the gene expression, and these will enable us to to express the gene only in inhibitory neurons. And so we packaged these in AAV9 and injected in mice. And looking at immunohistochemistry analysis, we could see that when we had only the N-terminus expressed, we were able to identify it using antibody against the tag on that part, or when we have the C-terminus, we could do similar kind of analysis using this antibody. And when we have the 2 of them, we could identify both of them expressing in the tissue. And we could label the tissue with GAD67 and then evaluate how many of this HA tag or one of the C terminus or the N terminus part are expressed in inhibitory neurons. And we saw that all the HA tag are expressing in inhibitory neuron, showing that we have high specificity of expression. The same thing for the tag on the C terminus of the channel. And when we look and say, are these tag expressing in all GABAergic neurons, we saw that the completeness of targeting GABAergic neurons was variable between 30 to 80%, depending on the individual cases. And so we took then these constructs and vectors, tested for efficacy in animals, and what our experiment was set so that we inject the vector at P0 in the mice, waited until P21 to monitor them all the way to P70 when disease manifestation is obvious in our animal model. We had two control conditions. One is where we had a control virus, and then we had untreated mice. And then we had two treated conditions where in one condition we had the virus built in-house, which is at the Allen Institute, and the other, the virus was built commercially at PacGene. And the difference between the two is just that the PacGene virus was of high quality and high purity. And so to test for seizure susceptibility, we use a test that we develop in our lab where we can implant a thermal probe into the mouse and use this temperature controller to elevate the body core temperature of the mouse in a step fashion by half a degree every 2 minutes until we have a seizure or we reach 42 degrees and stop the experiment. The outcome that we are looking for were the induction of myoclonic seizures or generalized tonic-clonic seizures. And so these are the results. You could see is that our commercial vector was very efficient in preventing seizure. The in-house showed strong efficacy, but was not complete. And this, when we look at the myoclonic seizure, we saw that we were able to prevent them up to 40 degrees. But after that, we saw that some of the mice started having these seizures. And the cumulative number of these seizures were suppressed in the cases of the treatment very substantially. And here we just, in the interest of time, I'm just going to go quickly here and show that for the generalized tonic-clonic seizure, you could see that we were able to suppress them very efficiently to up to 41 degrees Celsius. So our treatment was working. And in the interest of time here, I'm just going to jump to the conclusion and show you that we are very happy that this treatment is working, and we could see a very strong suppression of SUDEP symptoms and even seizure symptoms using this approach. And we are continuing testing some other outcomes such as spontaneous seizures using EEG. And then we would like to also test whether targeting all the neurons will not be as efficient as being very specific to the cells that are actually driving the phenotype, the interneurons. And we will also go in slices where we'll test the interneurons and confirm that their activity is rescued. And I'll stop there and take the questions.
Thank you, Dr. Kalume. Does anybody have any questions for Dr. Kalume?
I do. Yeah, Franck, that was terrific. I really enjoy hearing the progress that you're making, because I think I'm hopeful that, in our combined lifetime, we're going to have a translational model where, we can start clinical trials. In your mind, what do you see as the top 2 or 3 barriers to bringing this therapy to the bedside? I imagine one are the vectors that, getting a high efficiency transfection and a great number of neurons that'll alter the clinical phenotype is going to be an issue. What else do you see as barriers?
Thank you, Jay, and I think that's a big barrier, and in fact, it's something that we are studying and trying to optimize in our work. And related to that is also here we are working with a small brain, almost the tip of my finger. But once we try to translate this to clinic, we'll have to deal with larger brain and try to deliver this type of therapy specifically in the cells of interest and on a much larger volume type. So that's a big problem. The other thing that we are looking at is that how can we do this from the periphery, because not everybody will have the skills that the group has here to go and intervene into the brain and deliver the vector. Is it possible to deliver the vector from the periphery, from the with an injection at that site, and letting the virus to go all the way, go to the blood-brain barrier and target the cells that they supposed to. And this is something that is being worked on by Viviana Guadagnaro at the Caltech, where she is engineering these AAV vectors that will cross the blood-brain barrier and target the specific cells, and either by just engineering the capsid to be able to do that, or by adding the enhancer or promoters, as we did in this preclinical experiment.
Thank you, Franck. That's very, it's a fascinating thing. I hope you get your transfection percentage up high, and that this is a solution for this really unfortunate condition and other epilepsy conditions. So great having you as a partner and in the Children's Hospital Research Institute. All right.
Thank you.
Thanks, Franck. We won't make it 5 years next time. All right. Without further ado, Patrick Fillingham, PhD. Patrick grew up here. He went to Cal Poly for his mechanical engineering degree. Then he did a mechanical engineering degree, both MS, followed by a PhD at the University of Washington. He also got an applied math degree while he was here, so he double majored. He is working at SANS in the Department of Neurological Surgery with our neurologic surgeons. And I saw that he won a Ron Crockett Endowed Fellowship. Ron Crockett is a huge supporter of not only athletics, but also he's a graduate of the engineering school before he started his own company, an offshoot of Boeing. So obviously well-trained Patrick, and he's doing some interesting work with Mike and Lewis. So very important, and I guess I can also say the SANS group has been very successful. Mike just will be renewing his grant, and he got a ridiculously amazing score on his renewal. So we're all celebrating that now. That's fabulous. You don't see scores in the single digit percentiles and impact over 20 or over very often. So congratulations for the SANS group and Patrick being one of the best examples of that group for fusion of engineering with neurological surgery. So Patrick, without further ado, it's great having you here. You can launch.
All right, thanks so much, Dr. Ellenbogen. I appreciate the introduction. I am going to be discussing our work on the finite element simulation of endovascular aneurysm coiling. And if I have some time afterwards, I'll also discuss our work on modeling the venous sinuses for IIH diagnosis. So a quick overview. As we all know, cerebral aneurysms still remain a significant clinical challenge, many of them resulting in disability or death. Recently, endovascular coiling has emerged as a more common and effective treatment, but there's still a lot of imperfections and a lot we don't know about why the treatment fails in some cases and why it's successful in others. The basic principle is to embolize the aneurysm with a bird's nest-like structure of fine platinum coils, and reducing the flow and causing clotting to allow the aneurysm to heal. But there's still recurrent rates from 20 to 40%, and there's not a completely well understood hemodynamic reason for success versus failure. And so what we want to do is create high fidelity simulations of the process so that we can better understand the physics, the hemodynamics, and how that relates to the cell biology, and how we can use all of that information to help design better treatment options. So the main tool for doing this, along with the finite element method, which I'll discuss in a second, is computational fluid dynamics simulation. So if any of you are familiar with Mike's work, you'll know that he has spent the last 6-7 years ago developing this method for patient-specific aneurysm simulation so that we can quantify the hemodynamics of the aneurysms both before and after treatment. So below here, you'll see an image of a successful treatment on the left and an unsuccessful treatment on the right of a endovascular stenting. And so the idea here is that when you reduce the flow by a significant amount, you're more likely to have success than when you don't. With stenting, it's a little easier to do these simulations because the geometry is a little bit less complex, right? So these simulations have been more successful in distinguishing between success and failure. For the coiled simulations, the coil mass is very difficult to quantify. So typically in these types of computational simulations, it's just treated as a homogeneous porous medium, which we all know is a pretty faulty assumption, right? So treating the mass as a homogeneous medium, we miss out on a lot of the intricacies and details. For example, jetting into the aneurysm neck won't be captured if we have a gap in the coil that is more porous, or if we have some better packing density on one side than the other, then we'll have uneven forcing, which can lead to recurrence or rupture. So all of these details we want to be able to capture when we do our simulations to get the most accurate and high fidelity picture of the hemodynamics. So that's where the synchrotron microtomography comes in. And as Dr. E just mentioned, this is the R01 renewal that Mike just submitted. So he has developed a method for 3D models, developing 3D models of these aneurysms, 3D printed models, and so in vitro models that he then treats with the same coils as were used in vivo. And then these are used in a ultra high resolution micro CT so that we can get these high resolution, high fidelity images of what the coil actually looks like. And so then these physical coil geometries can be used in the simulation instead of the virtual coils. Now, this is a great approach, but the problem is we still can't do these micro CT scans in vivo. So there's no way to get these high fidelity scans without these synchrotron scans where we have to ship off these 3D models. So we would like to be able to get this level of fidelity without having to do the in vitro study and focusing directly on in vivo. And so that brings us to these virtual coil geometries. So that's the finite element simulation. So the finite element simulation solves the solid equations of motion for the elastic coils. And so these coils are highly complex, as shown below. They have 3 different characteristic diameters, right? So it's a tightly wound coil with a really, really small primary diameter around a slightly larger secondary diameter. And then the tertiary diameter is kind of to represent the shape of the aneurysm. So all of these complicated geometries are difficult to model directly. And so to get as accurately as possible, we've worked with the device manufacturer to get these high fidelity drawings you see here. So we know exactly what the coils look like, exactly what the material properties are, and that allows us to get a more accurate representation in the finite element simulations. So the simulations go through the whole process of treatment. We package these pre-shapes you see here into a catheter so that they get the pre-packaged stress and strain accurate. That catheter is then advanced along the artery virtually into the aneurysm geometry, and then placed at the angle to match the in vivo. So we use the 3D angio to try and match the catheter placement and angle so that everything is accurate. These are it's a chaotic process, right? It's going to be very difficult to match it precisely. We want to get as close as possible so that we can get good geometric representations of the aneurysm coil. And after simulation, we were able to get fairly good results. So we looked at 4 different aneurysm cases where we had micro CT geometry already, and I wanted to compare the virtual geometry that we were able to generate using the finite element simulation. So above is the micro CT geometry, below is the FEM geometry, and underneath that are some of the accuracy measures we use to compare. So while the representations are never going to be perfect due to the chaotic and random nature of the process, we were able to relatively accurately represent the porosity of the coil geometries. So the porosity is essentially what's been found to be most significant for this flow, right? Essentially, it's going to be the resistance to the flow. And so what we did is we took these 3D geometries and we voxelized them. We created a binary 3-dimensional space where each cube is defined by a 1 or 0, where there either is an element of the coil or there is not, right? And so that allows us to create an accuracy score between the two, which on average is around 82% of the voxels were aligned. So yeah, it's not perfect, but it's pretty good. We're accurately capturing where the concentration of the coil mass is. The Pearson correlation average around 0.7, and then the error in these porosity maps is an average of about 8%. So we're getting much closer to accurately representing the coil mass than we would otherwise be able to do in vivo or by representing it as some sort of porous medium. These highly resolved FEM simulations are giving us a much more accurate representation of the coil mass so that we can more accurately quantify the hemodynamics using the computational fluid dynamics simulations. So these geometries kind of serve 2 purposes. One, a pre-treatment simulation like this, we could see geometrically whether we think it's going to be an effective strategy, right? We can see whether that coil mass porosity is concentrated along the outer edge, whether we're going to have jetting, whether we're going to expect a high reduction in flow or a less effective reduction in flow. And those types of things we can do kind of by observing the geometry, but to get a more in-depth picture of the hemodynamics, that's where the computational fluid dynamics simulation comes in. And so we did a CFD simulation using the FEM geometry, using the CT geometry, and then also using the porous media method, so we can compare how much more accurately we're representing the hemodynamics using these finite element or virtual coils as opposed to the traditional method that's used in literature. And we came up with some really promising results. So for each of these patients, we calculated the parameters, the hemodynamic parameters that are most correlated with successful versus failed treatment. So that includes velocity at the aneurysm neck, both the average, the time average, and the peak. And that, that generally represents how much flow is going into the aneurysm dome. We want to reduce that as much as possible, and we need to accurately represent that as much as possible if we're going to try and predict recurrence or rupture based on these parameters. The next parameter is the velocity in the entire dome, both the peak and the average. Then we're looking at the wall shear stress, so the tangential force that the flow exerts on the aneurysm wall, the lumen wall. And so we look at that across the entire dome. We also look at that across the neck. And we then look at the gradient, the spatial gradient. So that's how the wall shear stress is varying in space. And then finally, we look at the oscillatory shear index, and that represents the OSI. That represents how the wall shear stress is fluctuating in time, right? So a more stable aneurysm will have a more stable set of wall shear stress. It's not going to be fluctuating a lot in magnitude and direction. So the more that we have fluctuations in that shearing stress, the less stable the aneurysm will be. So by comparing all of these between the micro CT simulations, the finite element simulations, and the porous media, we see that by representing the coil mass using our virtual coils, we get a much more accurate depiction. And that can be shown mostly in the bottom row there, the cohort mean. You can see that on average, we're looking at 6-7% error for the neck velocity of the FEM simulations, where we're looking at 55 and 36% error for the porous medium simulations. So drastic reduction in error in something as simple as how much flow is entering the aneurysm, right? So if we can't accurately capture that, then we're never going to be able to predict the actual outcomes here. So this is a big step forward in using hemodynamic simulations to more accurately represent these coiled aneurysms. And overall, we get like a 58% reduction in error on average across these parameters of interest. And on the right here, you can see this is a comparison of the wall shear stress, and the trends and the shapes and the contours are very, very similar. The magnitudes are very, very similar. So we feel good about our ability to accurately represent those hemodynamics. And then conclusion. So here's a little bigger picture of two coil geometries and another representation of how accurately we're able to capture this. So this is the X, Y, and Z shearing stresses along the dome plotted for the case using the micro CT or synchrotron scanned geometry versus the finite element generated geometry. And as you can see, we're tracking very well. The general correlation on these shear stresses is around 0.97. And so these FEM generated coils can help us more accurately represent aneurysm hemodynamics so that we can get a more predictive set of hemodynamic parameters to investigate in future more large scale trials, right? So we want to use this to look at successful treatments and unsuccessful treatments going forward so that we can characterize the hemodynamic differences more accurately than was previously possible. And so then the long-term goal is to develop a protocol where prior to treatment, especially for these trickier aneurysms where it's not entirely clear what the best method to treat is, we can test out a set of different coiling strategies using different sizes, using different combinations, and then calculate both the geometric factors and the hemodynamic factors. And among several different coiling strategies, we can then see what we would predict to be the most hemodynamically effective. So that's the basic premise there. I think I have 2 more minutes, so I'm going to quickly go over the IIH work we're doing as well. So we want to come up with a way for non-invasively measuring pressure gradients along the dural venous sinuses. So here's a 3D recreation of some stented sinuses, and we want to use a combination of MRI and computational fluid dynamics to calculate the pressure gradients so that we don't have to use invasive manometry or pressure tap manometry to evaluate whether these patients would be eligible for stenting versus stunting treatment. So if we can non-invasively determine a patient is eligible for stenting, that is a big step forward in helping reduce the necessary surgical procedures and the invasive testing typically done to measure pressure gradients. So in order to do this, we use phase contrast MRI to measure the CSF blood flow rates in the sinuses at the jugular vein, the straight sinus, and the superior sagittal sinus. And so this allows us to quantify, if we can quantify the flow at the edges of the domain, we can then quantify the flow throughout the domain. And that allows us to calculate the pressure gradient across those stenoses to determine whether stenting would alleviate the pressure in a specific patient. And so we recently submitted this work on a single patient. You can see here is the pressure gradient on the left side and the velocity magnitude on the right side. You see that increase in velocity right along that stenosis there is associated with a giant pressure drop, right? So in these graphs on the bottom, you can see as the pressure goes up, or sorry, as the velocity goes up, the pressure goes down, right? We have a lot of speed going through there, the pressure drops. And so we measure that directly. And when we compare it with the manometry that was taken on this patient, the results are really promising. So we can measure the pressure drop across these stenoses from the superior sagittal sinus down to the jugular veins within plus or minus 5% of the measured value. So we think that we can hopefully automate this process so that it can be a useful clinical tool. There are tools out there to do machine learning models to automatically do the segmentation and solve the equations of motion so that someone like me would not be necessary for this to be clinically useful in the future. So we want to be able to create a quick automated tool based just on MRI that will allow for the determination of whether a patient would benefit from stenting across those stenoses. And that was really quick, but that sums it up. I want to quickly acknowledge the Cacho family and Mark Robeson for supporting my work. And special thanks to Mike Levitt, Alberto Aliceta, and Jalal Andre for their help with